Welcome to the Funnel Effect. Today we are undertaking a deep dive into something truly, well, profoundly counterintuitive, really. It's the tragedy of sudden cardiac death, or SCD, happening in young, competitive athletes. I mean, these are the individuals we often see as the absolute picture of health, peak physical fitness. Yet devastatingly, some harbor these hidden conditions. Conditions that can prove fatal during the very activity that, defines their lives. Our source material for this analysis is a really comprehensive paper. It's the JCC State-of-the-Art Review on Sudden Cardiac Death in Young Athletes. The authors are Gerardo Finocchiaro, Joseph Westoby, Marian Shepherd, Michael Papadakis, and Sanjay Sharma. A stellar group.
That's right. And our mission today really is to give you, our listener, a quick but thorough understanding of this really complex topic. We need to go beyond just the headlines, establish the true scope of the epidemiology before we can really meticulously explore the diverse and often hidden causes that stop a young heart.
Absolutely. And crucially, we're going to spend significant time on what might be the biggest diagnostic challenge in sports cardiology. How do you definitively tell the difference between a normal, highly adapted, healthy athlete's heart, those physiological changes from intense training, and a heart that's hiding a deadly pathology? And finally, we'll dig into the intense debate around prevention strategies, screening policies, and that critical shift towards more personalized, shared decision-making about continuing exercise. Okay, so let's start with the numbers. Epidemiology. Whenever this hits the news, the reported incidence rates for sudden cardiac death seem to, they jump all over the place depending on who you read. Why is it so hard to pin down one reliable number for SCD in young athletes?
Yeah, it's fascinating, isn't it? The variability isn't necessarily bad research. It actually reflects really inconsistent definitions across different studies globally. When you try to compare incidence rates, you immediately hit like three major variables. First, who counts as an athlete? Is it the high school JV player or, an elite Division I athlete training 20 hours a week? Big difference.
Right. Second, which sports are included? Contact sports, endurance. And third, and this is key, are the studies tracking only sudden cardiac death, SCD, or do they also include sudden cardiac arrest, SCA, where the person actually survived because someone intervened quickly? So if you're not comparing apples to apples across these different regions and studies, the data is naturally going to look, chaotic.
That distinction between SCA survival and SCD death is really critical then. Could you maybe synthesize some key data points just to show the practical range we're talking about, depending on the group and definition?
Certainly. Let's look at the U.S. first. The NCAA database is pretty robust, covering competitive athletes aged, 17 to 24.
Yeah.
They reported an incidence of about 1.9 per 100,000 athlete years. That's over a long 10-year review. Yeah. So it gives us a decent baseline for U.S. college competition.
And then there's the number that always comes up in policy debates, the one from Italy. Absolutely. Italy provides probably the single most compelling piece of evidence for a specific policy. Before the Veneto region put mandatory 12-lead ECG screening policies in place back in the early 80s,
right,
the reported SCD incidence was around 3.6 per 100,000 athlete years.
Wow.
But after they implemented screening, that rate dropped dramatically.
Oh, how dramatic.
Down to 0.4 per 100,000. That's an 89% reduction. It's pretty hard to argue with a statistic that links a screening tool so clearly to such a massive drop in deaths.
89%. Wow. That figure really does shift the entire conversation around screening cost-effectiveness.
Yeah.
We'll definitely circle back to that debate later. But the force also mentions that even with screening, some specific groups can still show much higher risk than that overall NCAA average.
They definitely can. For example, there was a recent large study looking specifically at screened adolescent football players, soccer that is. It showed a surprisingly high incidence, 6.8 per 100,000 athlete years.
That's higher.
Yeah, much higher, which just goes to show that risk isn't spread evenly. It varies a lot based on the sport, the intensity, the specific age group.
And it's crucial, isn't it, to keep perspective here. We're focusing on young athletes, but the source points out that SCD incidence is actually statistically much higher in older athletes, those over 35.
That is such a critical piece of context, and it often gets lost, in the public discussion. There was a large Danish national study. They estimated the incidence in young athletes 35 and under was somewhere between 0.47 and 1.21 per 100,000 person years.
Okay.
But it jumped significantly to 6.64 per 100,000 person years in the older athletes. And the causes shift dramatically, too, in that older group and moves away from these inherited structural and electrical issues we'll talk about and focuses much more heavily on acquired conditions like, coronary artery disease, atherosclerosis,
Okay, that makes sense. Now, moving beyond age, the source highlights specific demographics that carry a really disproportionate risk. This might be one of the most shocking and frankly important takeaways for anyone listening who works in sports or medicine. Let's talk about ethnicity in sport.
Yeah, the data consistently points to a significantly higher risk among athletes of African or Afro-Caribbean origin. And it's not just a slight increase, it's a profound disparity.
Tell us about that NCAA data point on this. It's pretty alarming.
It is genuinely alarming. There was a major prospective study in the U.S. using the National Center for Catastrophic Sports Injury Research Registry, and it pinpointed the single highest reported annual incidence rate among African-American male NCAA Division basketball players. The incidence was 1 in 2,087 athlete years.
Wait, say that again? 1 in 2087?
No, 1 in 2,087.
That's orders of magnitude higher than the overall NCAA average you mentioned, the 1.9 per 100,000, which is more like 1 in 52,000. So for this specific group, in a high-intensity, explosive sport like basketball, any underlying conditions they might have are manifesting at an extremely high aggressive rate. Why? Why this specific and extreme risk?
That really is the million-dollar question for sports cardiologists. The source suggests a few factors might be converging. First, this population has a higher baseline prevalence of certain cardiac adaptations, those athletes' heart changes we mentioned, that can overlap and mimic serious conditions like hypertrophic cardiomyopathy. Makes early diagnosis really tough.
Okay.
Second, there's some evidence suggesting a higher prevalence of certain underlying structural or electrical diseases in this group, or maybe these diseases just express themselves more aggressively under the stress of high-intensity training for explosive sports like basketball. And third, basketball involves these rapid, maximal anaerobic bursts, right? Big sympathetic surges, adrenaline rushes, and those can trigger fatal arrhythmias more easily than, say, steady-state endurance exercise.
And we also can't ignore the gender difference. The source says cardiac arrest during sport seems to be more than 10 times lower in women compared to men.
Yeah, that's a really robust finding. You see it across pretty much every database. Even as women's participation in competitive sports has, thankfully, surged over the past few decades, the risk just remains significantly lower for women. The source explores a few potential reasons. Hormonal factors, maybe? Specifically estrogen, perhaps offering some protective effect on how the heart adapts and remodels.
Interesting.
We also see sex differences in how the heart adapts to training. And crucially, men seem to have a higher prevalence of myocardial fibrosis, that's scar tissue in the heart, which is a known setup, a substrate for fatal arrhythmias. So understanding these physiological sex effects is really a critical area for ongoing research. We need to figure out what exactly is protective in women.
Okay, let's transition now from the who and how often to the why. What are these underlying hidden conditions that turn an athlete's heart into, well, a fatal substrate? And the foundational step in answering that, as the source points out, is something that's sadly becoming less common globally: the detailed postmortem examination, the autopsy.
Yeah, and this point just cannot be stressed enough, especially when you think about the hereditary implications of these deaths. A detailed cardiac autopsy done by an expert pathologist who follows a standardized protocol. It's not just a formality for the statistics. These deaths are often the very first sign of a hidden inherited disease, a hereditary condition.
Right.
So the autopsy results give the definitive diagnosis, and that diagnosis then dictates the immediate clinical assessment and potentially life-saving screening for surviving first-degree relatives, siblings, parents.
Yet the data shows this universal decline in autopsy rates, which feels like an ethical failure as much as a diagnostic one.
It's a profound failure, absolutely. The source gives some startling examples. There is a FIFA report on sudden death in young footballers across 67 countries. Out of 617 cases, only 127 had an autopsy.
Wow.
Think about that. Hundreds of families left without answers. And another recent review highlighted that up to 40% of SCDs in young people under 50 in Europe didn't have an autopsy. Without that crucial step, the diagnosis often just defaults to sudden unexplained death, or SASAGES, which is just a devastating non-answer. It leaves families in this diagnostic limbo, wondering if they're carrying the same genetic risk.
It's terrible. Okay, let's delve into the specific causes now, starting with the structural abnormalities. The big one structurally is hypertrophic cardiomyopathy, or HCM.
Right. HCM is sort of the heavyweight champion of inherited heart diseases in terms of how common it is. Affects about 1 in 500 people in the general population. It's defined by unexplained left ventricular hypertrophy, LVH, where the heart muscle gets thicker for no apparent reason, like high blood pressure.
Yeah.
It's frequently cited as the main cause of SCD in young U.S. athletes. Depending on the study, the region, the focus, it shows up in anywhere from 2% to maybe 36% of cases globally.
And what's actually happening inside the heart muscle in HCM? What does the pathologist see?
Pathologically, at autopsy, you're looking for a significant increase in the heart's weight and/or asymmetric LVH,
Asymmetric.
meaning the thickening isn't even. It often affects the septum, the wall between the ventricles, much more than the other walls. And crucially, under the microscope, histologically, you find widespread myocyte disarray. The muscle fibers are just disorganized, jumbled up, not neatly aligned like in a healthy heart. Oh, and we should note, the 12-lead ECG is an incredibly powerful screening tool here. It's abnormal in over 90% of HCM cases.
90%. That's high.
Okay.
Okay, the second major structural cause is arrhythmogenic cardiomyopathy, ACM, which used to be called ARVC, focusing only on the right ventricle.
Exactly. ACM is characterized by this progressive destruction of healthy heart muscle. It gets gradually replaced by fibrofatty tissue, basically scar tissue and fat, while initially people thought it was mainly a right ventricle problem. Hence, ARVC, we now understand the left ventricle is often involved too. So the broader term ACM is preferred. This condition is particularly dangerous for athletes because studies strongly suggest that the stress of chronic, high-intensity exercise actually accelerates the disease process.
Oh, wow.
Yeah, it seems to worsen the fibrofatty replacement and increases the tendency for fatal arrhythmias. It's a major cause of SCD, particularly noted in some regional studies, like those from the Veneto region in Italy.
So the very thing that defines their life, the exercise, is literally damaging their heart muscle more rapidly. That's a terrible paradox.
Yeah.
It truly is. The autopsy finding typically shows this telltale fibrofatty replacement, often in what's called a subepicardial distribution, meaning closer to the outer surface of the heart muscle.
Okay. Moving on, there's a structural condition mentioned that sounds a bit like a diagnosis you arrive at when other things are ruled out. Idiopathic left ventricular hypertrophy or idiopathic LVH.
Right. This is considered a novel entity, meaning its recognition is relatively recent. It's found in up to 30% of SCD victims in some very selective studies. Idiopathic LVH is defined by unexplained severe LVH, so the heart weight is significantly heavy, over 500 grams in men, or the wall thickness is over 15 millimeters, and this is key, without that classic myocyte disarray we see in familial HCM.
Oh, okay. No disarray.
Right. Studies suggest it might be genetically and pathologically distinct from the typical inherited form of HCM, which raises the possibility that it could be an acquired pathological response to stress, perhaps, including intense training in people who are genetically susceptible somehow. Still a bit of a puzzle.
Now let's talk about the plumbing, the vessels feeding the heart. Coronary artery anomalies, CAAs. These are the second most frequent cause of SCD in the U.S. How does a simple anatomical variation become fatal?
CAAs account for about 17% of deaths in young U.S. athletes. The problem isn't just that the artery starts in the wrong place. The critical issue is the path it takes afterwards. The most dangerous scenario is when a coronary artery, usually the left main or the right coronary artery, originates from the wrong aortic sinus, the wrong starting point off the aorta, and then follows what's called an interarterial course.
Interarterial course,
Meaning it runs between the two great arteries, the aorta and the pulmonary artery.
Okay. Can you walk us through the mechanism there? How does physical effort actually cause that vessel to close off?
Right. So during intense high-level exercise, you get that massive sympathetic surge, the adrenaline rush. This leads to two key physical changes. First, heart rate goes way up, demanding maximum blood flow through the coronaries. Second, and crucially, the aorta and the pulmonary artery, these big vessels sitting right next to each other, they expand and swell because of the huge volume of blood pumping through them at high pressure.
Makes sense.
Now, if that coronary artery happens to be running between these two expanding great vessels, the interarterial course, it gets physically compressed, squeezed shut, basically, like it's in a vice.
Wow.
This compression leads to acute myocardial ischemia, a sudden lack of oxygen to the heart muscle. And that ischemia is what triggers a fatal ventricular arrhythmia.
That mechanistic explanation makes it terrifyingly clear. The vessel is perfectly fine at rest, but the sheer physics of peak effort becomes lethal. Is myocardial bridging, MB, similar?
MB is less frequently implicated as the primary cause. MB is when a segment of a coronary artery dips down into the heart muscle itself, instead of just running along the surface. While it's actually pretty common in the general population, it's only reported as the definite cause in maybe 0.5% to 3% of SCD cases. The compression is generally less severe than with an interarterial anomaly, although it can still cause symptoms in some people.
Okay, so we've covered the main structural causes. But what about when an athlete dies suddenly and even a meticulous expert autopsy reveals a completely structurally normal heart?
That's when we know the problem likely lies in the heart's wiring the electrical system. We enter the realm of primary electrical abnormalities. When the heart is structurally silent at autopsy, the term often used is sudden arrhythmic death syndrome, or SAIDS. These are usually inherited channelopathies problems with the tiny ion channels that control the heart's electrical impulses.
And the major channelopathy people might have heard of is long QT syndrome, LQTS.
Right. LQTS is defined by, well, a prolonged QT interval on the ECG. This interval represents the time it takes for the heart's ventricles to recharge or repolarize after each beat. A delay here makes the heart electrically unstable and prone to life-threatening ventricular arrhythmias, especially that characteristic twisting rhythm called torsades de pointe. For athletes, the danger is amplified because these fatal events are often triggered by adrenergic surges, that very adrenaline rush that comes with competition, or by electrolyte imbalances, both of which are common in high-level training.
Then there's Brugada syndrome, BRS.
BRS is another inherited disorder, this one affecting the sodium channels. It's characterized by a very specific ECG pattern called the type 1 Brugada pattern, seen in the right precordial leads, V1 to V3. Interestingly, SCD in Brugada often occurs at rest or during sleep, when vagal tone, the influence of the vagus nerve, is high. However, for athletes, the risk might be triggered by extreme physiological stresses like hyperthermia, getting really overheated during intense exercise, or perhaps that enhanced vagal tone, which is itself a common side effect of intense training. Both factors can potentially promote the fatal arrhythmias associated with the syndrome.
And finally, in this electrical category, catecholaminergic polymorphic ventricular tachycardia, or CPVT.
CPVT is defined by stress-induced bidirectional ventricular tachycardia. It's highly specific in that it usually requires physical or emotional stress to actually show itself. Unlike many other electrical diseases, the baseline ECG when the person is resting is often perfectly normal.
So how do you diagnose it?
It means you need active provocation. Exercise tolerance testing is absolutely key. You need to see those characteristic ventricular premature beats, or the defining bidirectional VT, which typically only appears when the athlete's heart rate gets elevated. It's caused by mutations, often in genes like RYYR22 or CCASQ2-2, which are involved in controlling calcium release within the heart muscle cells.
Before we move to the diagnostic challenge, let's quickly touch on a couple of other factors. Commotio cordis, that's not really a disease, right? It's more of a mechanical event.
That's correct. Commotio cordis is SCD triggered by a blunt, often relatively minor impact directly to the precordium, the chest area over the heart, like getting hit by a baseball, a hockey puck, an elbow. It's more common in kids and adolescents because their chest walls are more pliable. They transmit that impact energy more directly to the heart. The timing is absolutely critical. The impact has to occur within this tiny window, maybe 10 to 30 milliseconds, precisely on the upstroke of the T wave in the cardiac cycle. That precise timing destabilizes the electrical system and triggers ventricular fibrillation. It accounts for a small but significant percentage, maybe 5%, of adolescent athlete SCDs in some studies.
We really can't ignore the issue of performance-enhancing drugs, PEDs.
No, definitely not. Doping is a serious and maybe often underestimated cardiovascular risk factor. The abuse of substances like anabolic androgenic steroids, IAs, can lead to several dangerous changes in the heart: premature atherosclerosis, high blood pressure, and significant pathological left ventricular hypertrophy, which is different from the healthy athletic adaptation. Mortality among athletes who abuse AS is estimated to be maybe 6 times higher than in their non-abusing peers, and a big chunk of those deaths, around 30%, are attributed directly to cardiovascular causes. The source also mentions other dangerous things like stimulants, oxygen-carrying modulators. They all increase the risk of heart failure, coronary events. It's a serious issue.
And lastly, if the autopsy doesn't find a structural cause, the final tool in the box is the molecular autopsy.
Yes, post-mortem genetic testing. It's a vital and growing field. If the autopsy is inconclusive, what we call autopsy negative, then the molecular autopsy genetic sequencing offers a diagnostic yield of somewhere between 12% and 27% in these cases of unexplained SCD. And critically, that yield goes up significantly, maybe up to 39%, when you combine it with dedicated clinical and genetic screening of the athlete's first-degree relatives. Genetics are now essential, even when there is a structural disease found, like that idiopathic hypertrophy we talked about, to try and pinpoint the underlying cause and figure out who else in the family needs screening.
Okay, this brings us squarely into Section 3, the real diagnostic conundrum. This gets to the heart of the matter, doesn't it? Where all the knowledge we've just discussed has to confront the reality of the athletic body. We know vigorous training causes physical, electrical, structural changes to the athlete's heart. These are normal, beneficial adaptations, but they can look exactly like the deadly diseases we just cataloged.
This is truly the central challenge of sports cardiology. You're looking for sometimes very subtle differences that distinguish a healthy, super efficient heart from one that's hiding a potentially fatal condition like a cardiomyopathy. The physiological athlete's heart is typically characterized by a modest increase in LV wall thickness, maybe some biventricular cavity enlargement, but crucially, with preserved systolic and diastolic function. It's working well. This adaptation is most pronounced in large individuals, particularly men, especially those of African or Afro-Caribbean descent, who are involved in either high-volume endurance sports like rowing or running, or high-dynamic intensity sports like basketball or soccer.
Let's start with the most common and maybe most fraught overlap, differentiating hypertrophic cardiomyopathy, HCM, from just physiological left ventricular hypertrophy, LVH. Where is that gray zone that keeps cardiologists up at night?
The main gray zone for LV wall thickness is pretty well defined. It's between 12 millimeters and 15 millimeters. Just for context, getting a wall thickness of 15 millimeters or greater is extremely rare in a healthy athlete, regardless of their training level or ethnicity. That finding should almost always be considered pathological until proven otherwise.
Okay, so 15 millimeter plus is a big red flag.
Definitely. The problem is that 12 to 15 millimeter range. Well, it's not uncommon in high-level athletes. You might see it in 1.5% to 2.0% of white male athletes. But here's where that demographic difference is critical again. It's found in up to 13% of elite male athletes of African or Afro-Caribbean origin.
13%.
Yeah. So if you just disqualify every single one of those athletes based purely on that measurement, you'd be unnecessarily benching potentially thousands of healthy athletes from their careers, their passion. You can't do that.
Okay, so if an athlete's echo shows a wall thickness squarely in that 12 to 15 millimeter gray zone, how do expert cardiologists tell the difference? How do they separate benign adaptation from potential killer disease? We need those concrete red flags.
Right. It requires a multimodality approach. You have to integrate the ECG findings, the detailed echocardiogram, and often cardiovascular magnetic resonance, CMR imaging. You're looking for clues that suggest the heart muscle isn't just adapting strongly, it's struggling or diseased. So the red flags that would point towards HCM pathology, even in that gray zone, include things like, first, an asymmetric LVH pattern. Physiological thickening is usually pretty uniform, symmetrical. HCM often shows up as asymmetric thickening, frequently favoring the septum, that wall between the ventricles.
Okay.
Second, small left ventricular cavity size. If the muscle wall is thick, but the actual chamber inside is small, say, less than 51 millimeters in diameter, that suggests the thickening is encroaching on the cavity space. That's highly suggestive of pathology, not just adaptation.
Right, the chamber isn't getting bigger along with the wall.
Exactly. Third, diastolic function markers. This is arguably one of the most sensitive early indicators. Even if the squeezing function, systolic function, looks normal, a diseased, stiff heart muscle struggles to relax and refill properly. That's diastolic function. We look at specific measurements on the echo, like the E-prime velocities. A septal E-prime velocity less than 10 centimeters, or a lateral E-prime less than 12 centimeters. Those indicate impaired relaxation. Classic sign of stiff pathological hypertrophy. Got it. Fourth, an abnormal ECG. Certain ECG findings strongly point away from benign athletic adaptation. Things like deep T-wave inversions, especially in the lateral leads, or specific pathological Q waves. And finally, if you bring in CMR, which is excellent for looking at the tissue itself, if it detects myocardial fibrosis, that's scar tissue within that thickened heart muscle segment, well, that's a pretty definitive red flag for HCM, not simple adaptation. Fibrosis is the substrate, the setup for arrhythmias.
So the wall thickness measurement is really just the starting point. It's the totality of function, electrical activity, tissue characterization that ultimately determines the diagnosis.
Precisely. It's a mosaic of findings. Now, let's move to the overlap with arrhythmogenic cardiomyopathy, ACM. We know ACM primarily affects the RV, the right ventricle. But athletes' hearts, especially endurance athletes, also frequently show right ventricular dilation, so another overlap.
How do we distinguish a healthy enlarged RV from one that's undergoing that pathological fibrofatty replacement we talked about?
The key concept here is often proportionality. In healthy athletes, RV dilation is usually balanced with the size of the left ventricle. The ratio of RV end diastolic volume to LV end diastolic volume rarely goes above 1.2. It's a balanced enlargement. A truly pathological ACM heart, however, often shows regional abnormalities. You look for specific areas of the RV wall that aren't moving correctly, akinesia, meaning no movement, or dyskinesia, abnormal bulging movement. And again, seeing that subepicardial or mid-wall fibrosis on CMR is a critical indicator pointing towards ACM pathology.
And regarding the ECG overlap, particularly for those high-risk African Afro-Caribbean athletes, you mentioned a very subtle but vital distinction about T-wave inversions.
Yes, this is a complex but really crucial nuance. Anterior T-wave inversion, seeing inverted T waves in leads V1 to V4 on the ECG, is a hallmark of ACM. It's present in maybe up to 50% of patients. However, the exact same pattern of T-wave inversion can be a completely normal, physiological, benign adaptation in up to 25% of highly trained Black athletes.
So how do you tell them apart on the ECG?
The key differentiator often lies in what's happening right before the T-wave, at the J point where the QRS complex ends and the ST segment begins. In the benign physiological adaptation common in Black athletes, that T-wave inversion is usually accompanied by preceding J-point elevation. The ST segment kind of scoops upwards first. The absence of that preceding J-point elevation, or seeing a flat or downsloping ST segment before the inverted T-wave, that points more towards ACM. It requires really sophisticated interpretation, always considering the athlete's demographic background.
That really highlights why these diagnoses need to be made by expert cardiologists with specific training in this area. It's incredibly nuanced. Okay, let's look at dilated cardiomyopathy, DCM. Athletes, particularly endurance athletes like rowers and cyclists, can have massive heart chambers.
Indeed. Highly trained athletes in sports with a big dynamic component commonly show large LVs. End diastolic diameters often exceed 60 millimeters, and they might also show what looks like a mildly reduced left ventricular ejection fraction, LVEF, at rest maybe dipping into the 45% to 54% range. This can simply be because their highly trained heart is very relaxed and beating slowly at rest. High stroke volume, low rate.
So if an LVEF of 45% is typically considered mildly reduced in the general population, how do we confirm if this is pathological DCM or just a super efficient adapted athlete's heart?
Well, first we draw a hard line. Moderate or severe systolic impairment, meaning an LVEF below 45%, is not considered normal or benign, even the most elite athlete. That's almost certainly pathological DCM.
Okay, under 45% is bad.
Right. But for those athletes falling in that gray zone, say 45% to 54% LVEF at rest, we rely heavily on assessing their cardiac reserve. How does the heart respond to stress? Typically, this is done with exercise echocardiography. If the LVEF increases significantly, usually by 11% or more, from baseline rest to peak exercise, that strongly suggests it's just physiological adaptation. The heart has huge reserve capacity, it's just operating efficiently at rest. A truly pathologically dilated heart, however, usually won't show that robust increase in contractility under stress. Its reserve is limited.
Makes sense. Finally, let's tackle the overlap with the ion channel diseases, like long QT syndrome, LQTS, and Brugada, BRS. Here, the overlap involves electrical changes that training itself can cause, like slow heart rates.
Exactly. A prolonged QTC interval on the ECG isn't actually that uncommon in elite young athletes. Prevalence might reach 1 in 250 in some cohorts. Often it's just due to high vagal tone from training and increased cardiac mass. The measurement itself is notoriously tricky in athletes because of their low resting heart rates, their bradycardia. The standard formula most ECG machines use to correct the QT interval for heart rate. Bizet's formula often overestimates the QTC when the heart rate is very low, say below 40 or 50 beats per minute. This leads to a lot of false positives.
Why does Bizet's fail at low rates? Just a limitation of the formula.
It's essentially a historical formula derived from populations with average heart rates. When you plug in a very low heart rate, the mathematical correction factor it applies becomes disproportionately large, making the corrected interval look longer than it physiologically is. Other formulas like Fredericia or Hodges are often preferred at extremes of heart rate. So for athletes, international guidelines recommend specific cutoffs for suspicion of LQTS. Usually a QTC GU 400 N to 1 milliseconds for men and GEEP 481 milliseconds for women warrants further investigation. But the major red flag, the value that's highly indicative of true LQTS pathology, is a QTC interval GEEP 500 milliseconds. That needs serious attention.
But isn't there a more dynamic clue specific to LQTS and how the QT interval behaves during exercise?
Yes, absolutely. This is a crucial differentiating feature. It's the paradoxical failure of the QT interval to shorten appropriately, or sometimes its actual prolongation, as the heart rate increases during exercise. Especially in that early phase, going from rest up to maybe 120 beats per minute, a healthy heart should see that QT interval rapidly shorten as the rate climbs. Many LQTS patients, particularly types 1 and 2, fail to achieve this normal physiological shortening. That's a powerful sign of a defective repolarization process.
Very interesting. And for Brugada syndrome, BRS, what's the key ECG differentiation point we need to be aware of, especially thinking back to that African Afro-Caribbean athlete adaptation pattern?
Right. We have to be very careful not to mistake the true Brugada type 1 ECG pattern, that characteristic coved, downsloping ST segment elevation in leads V1 or V2, for the benign pattern of right precordial early repolarization. That benign pattern is very common in highly trained athletes, especially those of African or Afro-Caribbean descent. The key difference is the shape of the ST segment after the J point. In the benign athletic pattern, the ST segment is usually upsloping or concave upwards. In true type 1 Brugada, the ST segment is coved, sort of dome-shaped, and slopes distinctly downwards to an inverted T wave. Clinically, people sometimes use the ratio of ST elevation at the J point versus 80 milliseconds after it, STJ, ST80. It tends to be less than 1 in the benign pattern because of that initial upsloping, while it stays high in the true Brugada pattern. But morphology is key.
Okay, so to kind of wrap up section 3, the big lesson seems clear. Making an accurate diagnosis in an athlete requires an expert, holistic, and really meticulous interpretation. You need nuanced physiological and electrical data points, always balanced against the athlete's specific demographics, their sport, their training load. There's definitely no single magic number or finding.
That sums it up perfectly. It's complex detective work.
Now that we understand the diseases and the immense diagnostic difficulties, let's pivot to prevention and management. Pre-participation cardiac screening. As the source rightly calls it, this is the great debate. We have the American approach, largely focused on history and physical exam, and the European approach, which strongly prioritizes adding the 12-lead ECG. Why this major transatlantic divide, especially given that powerful Italian data we discussed?
Yeah, this divide is really rooted in competing philosophies about public health, resource allocation, and maybe even risk tolerance. The American guidelines from the AHA and ACC primarily recommend that 14-point history questionnaire and a physical examination. They've historically pushed back against mandatory widespread ECG screening,
Why?
mostly due to significant concerns about cost-effectiveness across a huge diverse population like the U.S., the lack of definitive randomized controlled trials proving it reduces mortality in all athletic settings, and worries about a high rate of false positives.
Okay. And conversely, the European Society of Cardiology, the ESC, guidelines champion the ECG, heavily influenced by that undeniable success story in Italy.
Exactly. That mandatory Italian screening program started in the Veneto region back in 1982 with the ECG. It's the cornerstone evidence for the pro-ECG side. That massive 89% drop in SCD incidence they achieved after implementing ECG screening really speaks volumes about the potential effectiveness of the ECG in picking up those underlying structural diseases like HCM and ACM before they cause a tragedy.
But if the Italian evidence is so strong, why the continued resistance or debate, particularly in the U.S.? What are the valid counter-arguments that the U.S. guidelines emphasize?
Well, the counterarguments are pretty significant, and they focus mainly on sensitivity, specificity, and the overall economic and social impact. First, sensitivity. That AHA 14-point history questionnaire, it's notoriously low in sensitivity. Why? Because, as we've discussed, most of these serious cardiac conditions are completely asymptomatic. The athlete feels perfectly fine right up until they collapse.
Right.
Some U.S. studies estimated that only about 31% of actual SCD cases could have been reliably detected beforehand, even if you use the history, the physical exam, and an ECG together. So even with ECG, you still miss a lot. Second, the economic and social cost, particularly around false positives. This is a major policy hurdle. If an ECG screening program has, say, a 5% to 10% false positive rate, which isn't unusual, especially using older interpretation criteria, you force thousands upon thousands of perfectly healthy athletes into expensive, unnecessary follow-up tests, echocardiograms, CMRs. And sometimes this leads to temporary or even permanent disqualification based more on fear or uncertainty than definitive disease. That causes huge psychological stress for the young athlete and their family, and it places an enormous financial burden on the healthcare system. all without a guaranteed, proven benefit on hard mortality endpoints across all diverse populations studied in large RCTs. It becomes a classic public health trade-off. Is the cost, anxiety, and unnecessary exclusion of many justified to potentially save the few?
That really reframes it, doesn't it? It moves beyond a purely medical question into a broader policy question about resource allocation and societal risk tolerance.
It absolutely does, and it underscores why this remains a genuine debate, not a scientifically solved problem everywhere.
Okay. Regardless of whether screening catches the risk beforehand, what happens when tragedy does strike on the field or court? What is the single greatest determinant of survival after a sudden cardiac arrest?
It comes down to one thing: time. Specifically, the time interval from the moment of collapse to successful defibrillation. Survival rates just plummet incredibly rapidly. They decline by about 7% to 10% for every single minute that's lost without delivering an electrical shock.
Every minute.
Every minute. If defibrillation happens within the first minute, survival chances can be as high as 90%, but after 10 minutes without a shock, survival is often close to zero. It's that critical.
So even while the screening debate rages on, aggressively deploying automated external defibrillators, AEDs, making sure the public knows how to perform cardiopulmonary resuscitation, CPR, seems like an absolute no-brainer.
It's critical. It's non-negotiable. There's a powerful French study highlighted in the source that shows exactly this impact. Over the study period, the actual incidence of sport-related sudden cardiac arrest remained pretty stable. But the survival rate for those who arrested survival to hospital discharge jumped dramatically, from about 23.8% up to 66.7%.
Wow, nearly tripled.
Exactly. And that stunning improvement was directly attributed to having AEDs immediately available at sporting events and increased public education and willingness to perform bystander CPR. Prevention isn't just about stopping the event from ever happening. It's also about ensuring there's a robust chain of survival ready when an event inevitably does occur.
Absolutely crucial point. Okay, let's shift focus slightly to management. For decades, the standard approach, if an athlete was diagnosed with a serious heart condition, was pretty much categorical disqualification. You're out. But the source highlights a modern, much more liberal approach emerging: shared decision-making. What sparked this change away from the strict ban?
Yeah, this is a really important evolution in sports cardiology. The change is driven by several factors coming together. One, a better understanding that the actual risk associated with many conditions is far more varied, more heterogeneous than we used to think. It's not black and white. Two, a growing recognition of the immense psychological, social, and physical benefits that continued exercise and participation provide for these individuals. Taking that away has consequences. And three, we've developed better tools for risk stratification ways to identify who is truly at high risk versus lower risk within the same diagnosis. So the newer guidelines really promote this shared decision-making process. It involves a careful, personalized assessment of the athlete's specific condition, their individual risk profile, their sport, their preferences, and then making a joint decision about participation.
Let's use hypertrophic cardiomyopathy, HCM, as the main case study here, since it was probably the condition most often associated with that automatic ban in the past. What do the new guidelines allow for HCM patients?
Right. Both the American AHC-ACC and the European ESC guidelines have evolved significantly. They now allow for the consideration of competitive sport or high-intensity recreational effort for specific, very carefully selected HCM patients. Who qualifies? Generally, it's asymptomatic adults who have what's termed morphologically mild HCM, meaning the heart muscle thickening isn't extreme, especially if they were already highly active before they got diagnosed, and crucially, if they lack any additional high-risk markers.
Okay, what are those specific high-risk markers that would still slam the door shut, leading to immediate disqualification or much more conservative restrictions?
We look for clear red flags that indicate either high electrical instability or severe hemodynamic problems. These would include things like a history of syncope, fainting, especially if it was exertion-related, a high calculated 5-year SCD risk score using the established risk models, like the ESC HCM risk SCD score. Typically, a score greater than 4% is considered concerning. Also, having significant obstruction to blood flow leaving the left ventricle at rest, what we call LVOT obstruction, usually above 30 millimeters of mercury gradient. An abnormal drop in blood pressure during exercise testing is another bad sign. Or, of course, having a documented history of dangerous ventricular arrhythmias, especially if they occur during exercise.
Okay, the source adds that critical layer of caution again regarding that highest risk demographic we identified earlier.
Yes, exactly. The guidelines specifically warn that this new leniency, this shared decision-making approach, is probably less applicable to that group we know is at highest risk. Adolescent and young adult men, particularly those of Black ethnicity, who are competing in those high dynamic, explosive sports like basketball and soccer. Because of the observed highly elevated risk in these specific cohorts, a more conservative management approach, leaning away from high-intensity competition, is often still warranted for them, even if they seem to meet the low-risk criteria otherwise.
And we should also probably mention the real-world data coming out now showing that athletes can live and even compete with implanted devices.
Yes, that's another important piece of the puzzle. Data from the Multinational Sports Safety ICD registry, that's Implantable Cardioverter Defibrillator Registry, confirms that many individuals with an ICD can and do successfully participate in vigorous exercise. Provided, of course, that they're closely monitored by experts and their device is programmed appropriately for athletic activity. While full contact collision sports are still generally discouraged because of the risk of damaging the ICD generator or leads, having an ICD no longer automatically means the end of an active athletic life for everyone. It's about careful risk assessment and mitigation, not just blanket restriction anymore.
Okay, moving to other conditions. What's the current thinking on arrhythmogenic cardiomyopathy, ACM, and exercise? Still very conservative.
For ACM, yes, the guidelines remain highly conservative and for very good reason. High-intensity exercise is generally not recommended. This is one condition where the evidence seems quite strong, mostly from retrospective studies, suggesting that chronic intense exercise actually appears to worsen the disease process itself, speeding up that fibrofatty replacement, accelerating the phenotypic expression, and significantly increasing the risk of arrhythmias.
So exercise makes it worse.
That's the concern. So, for individuals with a definite diagnosis of ACM, avoiding high-intensity competitive sport is strongly recommended, really as a strategy to try and slow down the progression of the disease itself. Now, for long QT syndrome, LQTS, the approach is, again, personalized, but it's based largely on the severity of the electrical phenotype, how long the QT interval actually is, and whether they've had symptoms. High-intensity exercise is definitely contraindicated if the athlete has ever been symptomatic, had syncope or a cardiac arrest, or if their QTC interval is severely prolonged, say consistently over 500 milliseconds. However, if the athlete has a milder form, maybe just a borderline QTC, is completely asymptomatic, and is optimally treated with beta blockers, which are the mainstay therapy, then competitive sport can be considered. But only after a really rigorous individualized assessment by an expert with close follow-up, usually annual surveillance.
Okay. And finally, let's tackle what might be the most ethically and clinically challenging management group: the genotype positive, phenotype negative dilemma, G plus P. These are the individuals who carry a known pathogenic gene mutation for one of these potentially deadly conditions, but they show absolutely no outward signs of the disease. Their ECG is normal, their echo is normal, they feel perfectly fine today.
Ugh, yeah. This is a massive knowledge gap, and it puts clinicians, athletes, and families in a really difficult position. It's a terrible bind. You have this tension between managing a known genetic predisposition for a future problem versus the person's current clinical reality, which is normal. The general sort of default attitude for many gene mutations has been to allow continued intensive exercise, but with the strong recommendation for regular, usually annual clinical surveillance, ECG, echo, maybe Holter monitoring, to try and catch the very first signs if the phenotype of the disease starts to emerge.
But there's a major exception to that, right?
Yeah.
Depending on the specific gene involved.
Yes, a critical exception. If the pathogenic gene variant happens to be in certain genes known to be associated with particularly high arrhythmic risk or aggressive disease progression genes like LMNA-WA, which causes laminopathies, often aggressive DCM and arrhythmias, or PKP22, a common cause of ACM, then the consensus often shifts dramatically. In these specific high-risk gene cases, because there's a recognized link between intense exercise potentially worsening the phenotype or increasing arrhythmia risk for those specific genes, avoidance of high-intensity competitive sport is often recommended. Essentially, they're managed almost as if they already have the overt high-risk disease based purely on the identity of the gene variant they carry, even if they look completely healthy today. It's managing future risk based on genetics.
That's a heavy decision. Okay, let's try to synthesize this complex picture as we wrap up.
Sure. So to recap our deep dive, sudden cardiac death in young athletes, while rare overall, is a truly catastrophic event when it occurs. The epidemiology consistently points towards young men, particularly those of African and Afro-Caribbean origin, especially when they're involved in high-intensity explosive sports, as the population carrying a profoundly higher risk.
And the underlying causes are incredibly diverse. We covered structural diseases like hypertrophic cardiomyopathy, which can masquerade as a normal athlete's heart. Arrhythmogenic cardiomyopathy worsened by exercise, coronary artery anomalies causing fatal compression during peak effort, and then the primary electrical channelopathies like long QT, Brugada, CPVT, where the heart looks structurally normal but is electrically unstable.
And that diagnostic challenge is just immense. It demands that holistic, expert approach we talked about, integrating all the clues, diastolic function, fibrosis on CMR, paradoxical QT changes during exercise, all filtered through the lens of the athlete's specific demographics and training profile.
Prevention relies on a two-pronged approach. Ideally, early identification through screening, where the Italian data strongly supports, including the ECG, despite the ongoing debates about implementation. And critically, ensuring swift intervention when an arrest does happen through widespread CPR training and immediate access to AEDs. That saves lives, regardless of screening. And the management landscape has shifted significantly away from just categorical disqualification towards that shared decision-making model, acknowledging that many athletes with mild or well-managed conditions can often continue competing safely, provided they are rigorously assessed, monitored, and don't have those high-risk features.
Which brings us to the future. What's needed next? The source highlights some crucial knowledge gaps. We desperately need large, prospective, global registries that use standardized data collection and, importantly, standardized autopsy protocols. This is essential to definitively pin down the true global incidence rates and the relative frequencies of all these different causes. We also need dedicated randomized clinical trials, which are incredibly difficult to design ethically in this population, to try and determine the optimal safe dose of exercise for patients who have known cardiac diseases. How much is too much?
Right.
And finally, large-scale longitudinal studies, perhaps leveraging new technologies like wearable devices or smartphone ECGs, are needed. These could help confirm the true cost-effectiveness and sustained benefit of different pre-participation screening strategies in diverse, large populations, hopefully helping to finally settle that transatlantic debate with more definitive data. So maybe here's a provocative thought for you, the listener, to mull over as we close. Given the extreme heterogeneity of risk we've discussed, where the danger can be so specific, tied down to an individual's ethnicity, their chosen sport, even the specific gene variant they carry, maybe the next frontier in sports cardiology isn't just about diagnosing the disease once it's apparent. Perhaps it's about truly understanding the long-term, specific mechanistic role that intense training plays on personalized genetic risk profiles. Moving beyond generalized guidelines towards genuinely tailored advice based on an individual's unique biology and genetics. Advice that could allow an athlete to truly maximize their performance while actively minimizing their own concealed dangers.
That's a fascinating and critical challenge for the future. Thank you for watching The Funnel Effect.